So, good evening, everybody, or everyone, as I used to say in UK. So, Francesco Sanguolci from Barcelona. I'm a urologist, and I'm very pleased to start this webinar today, which is one of the first of this year. And probably one or the more interesting one, I would say, because of the relevance that this topic, the theranostics, is going to have in the near future, if not already in the current practice. We are going to a little bit see what is the application, what is already ongoing on the theranostic in urological cancer, what is in view of development, and so we have three distinguished speakers talking about this topic. So we have the pleasure to have two medical nuclear medicine physician experts, and apart me also another urologist, and I will introduce them all together now, but obviously then again when will be their turn in for their presentations. Obviously, as usual, this is a webinar where we want to make it all the topics to stimulate the discussion, the interactions, so you will be free to make some questions writing in the question answer tab, so we'll try to address all the question during the webinar. There will be clinical cases for you also to have a bit of a glimpse of what these new treatment modality may involve in the clinical practice. And so basically now there will be the time for 1 hour of enjoyment. And it is my pleasure to introduce, I will put in the relevant order, Daniela Oprea, Professor Daniela Oprea from Nijmegen, Netherlands. She's a nuclear medicine physician and also member of the section of imaging, which is the one I represent. And with her support, obviously, we are covering this topic extensively, not just with the webinar, but also in other sessions during the main congresses. So one thing that obviously you can't, if you're attending the EU Congress in London next month, so you cannot miss the opportunity to attend also the session that we already prepare on this regard. So then will be the turn to have a brilliant presentation from Dr. Lena Unterreiner also she's a nuclear medicine physician from Munich, from the Technical University of Munich. And then also we'll end up with Giuseppina Casuccelli. She's a urologist in another university in Munich, the Ludwig Maximilian University in Munich. So Daniela now, she will provide us with a general overview of the principles of theranostics, what is it, what involves, and what is the general scenario. So thank you, Daniela, and the screen is yours.
Thank you very much. Welcome to everybody, and it is really my pleasure to discuss where are we now at this moment, and actually to introduce the next slide, please, which is about theranostics. Yes, I have no conflicts of interest to disclose for this presentation. Today, I will start by giving a talk on what is theranostics. I think nowadays it's really an important topic. I will explain how theranostics works, and I will provide the most important tips and tops from my nuclear medicine perspective, but I will also provide you some future perspectives, something that I think the urologic world and the imaging world will have to deal in the future. So nuclear medicine actually for decades was dealing with oncology and especially diagnostics. So our task is to find the cancer, find the hotspot, as you can see here on the left side. We are looking for the cancer cells. We are trying to diagnose, to classify the cancer, to diagnose patients, to restage the patients, one that these patients have been treated by the urologist or from other specialists. But what is now important, and I think for urology and for uro-oncology is something new, that especially in the last 6 to 7 years, we have entered the therapeutic arena. And this is something new. We are together with you practicing doctors trying not only to diagnose but also to treat the patients. And all of a sudden we have this wonderful concept of Theranostics, combining diagnosis and therapy, and actually being able on one hand to see what we treat and on the other hand to treat what we see. And this important concept, it helps us to actually make this theranostic synonymous with precision oncology. Why is important? It is important because we can see the cancer. It is important because we can treat only the cancer cells. We can somehow spare the healthy tissue. And meanwhile, we can provide and maintain the quality of life of our patients, which I think we all want to have. So the theranostic principle is quite easy. It all starts with a target. We need to have the target that is, for instance, a protein or some other type of molecule. And using a linking and a binding molecule, we can link this target to a radionuclide. On one hand, when we use a diagnostic radionuclide like a beta or a gamma emitter, we can use the target in order to diagnose the cancer. But on the other hand, we can also link this to a radionuclide, which is typically for therapy. Think about a beta or an alpha emitter, which will allow us not only to see after the treatment the cancer, but also to treat the cancer that we are able to see on our diagnostic scans. As you can see on the left side, once that we are using these diagnostic radionuclides, we will use products that emit beta or gamma energy, and therefore we are able to see the cancer. I think we all know and we all have heard about the PET-CT, and you can see on the left side just the simplification. We have the patient, and with our radioactive diagnostic radionuclide, we can see the cancer. As you can see here, the red spots. But once we are giving to our patients an alpha or a beta particle, we will cause single or double strand DNA breaks, and therefore we can induce cell damage. And this is really important because on one hand, we really need to know that there is enough expression, so we really have this target on the diagnostic scan, and on the other hand, we can use this target to destroy the cancer cells, to go directly to the cancer cells and to destroy them, and therefore to limit the damage in the tissue around these cancer cells. I think it's very important to differentiate between what is external beam radiation therapy and how does radionuclide therapy. The one external, the name is already saying, the external beam radiation therapy is delivering the radioactivity from outside, while the radionuclide therapy is actually working from inside. The patient is the one who is radioactive, and the radioactivity is coming from the body to of the patient to the cancer cells. So while the mechanism of action of radiotherapy and the radionuclide therapy, it's the same, basically radiation-induced killing of cells, we see that there is a big difference between these two elements. And you can see here in the upper part, in the sub-panel A, this is a principle of the radiation therapy, and irrespectively of how many cells are clustered together, all of them are getting the same level of radiation. While in the subpanel B, you can see here the patients treated with radionuclide therapy, and in this case, the absorbed dose is really influenced by the range of the emissions that you can see here, but also by the numbers of cells being clustered together, and also the numbers of the cells that have been targeted. The more cells are targeted and clustered together, the more impactful this range of the emissions will be, so our treatment will be even more beneficial. In the nuclear medicine field, we are actually working with 3 different types of radiation, and these radiations are really relevant for our field. As you can see on the on the left side, we are dealing with different types of radionuclides, but the most important are the photons, which are represented by X-rays and gamma rays. We are also dealing with electrons, Auger electrons, beta particles, and monoenergetic electrons, and the alpha particles. And in one moment, I will provide you some examples to understand. Nevertheless, from the multitude of the radionuclides that are currently available in the clinical practice, I have to say right now the lutetium-177 is one of our preferred radionuclide. It is a beta particle, and it is preferred in clinical practice because of the short tissue penetration depth, but also because of the lower abundance of gamma emissions. On the other hand, we are also happy that this beta tracer provide us also a small range of gamma rays, because in this way, after the treatment of the patient, we can perform a scan without injecting any additional dose. It's just the radioactivity from the body of the patient that allows us to make a scan and to see that we hit the target, and also later on to eventually appreciate and demonstrate the effect of our therapy. As you can see, this is just a simplification of what I have said, and I would like to use this example of prostate-specific membrane antigen as a target for prostate cancer. I told you the theranostic is all about linking a target, in this case a prostate-specific membrane antigen, which is a transmembrane protein, and this target can be linked with an diagnostic or a therapeutic radionuclide. This PSMA consists of a small intracellular domain and also a large extracellular domain in which we have a big center, and this center is actually the place where our PSMA targeted radiotracers, the ligands, can be linked. As we know, the PSMA is expressed in prostate cancer, in some cases even more than 80%. And as we can see here, we can use these PSMA targeting small molecules located at the extracellular domain compartment. We can use by a chelator and a linker to these positron or beta emitting radionuclides. And once again, depending on what we are using and what is the purpose of, we can use it for diagnostic or for therapeutic. As you can see here on the left side, and I really like these images, even if it's from 2016, so for some many years ago, but this was really a landmark publication in which actually all the aspects related to theranostics are presented. As you can see in the subpanel A, this is a patient, a castration-resistant prostate cancer, a patient having extensive metastatic deposits. Actually, all these hotspots are synonymous and compatible with metastatic deposits. This is the PET-CT scan. This is a scan performed after we link the target, the PSMA, with a diagnostic radionuclide. In this case, it was gallium PSMA 11. And we have this radionuclide to perform the scan and to see where is the cancer located. So to diagnose or to restage the patient in this castration-resistant stage. In this case, it is just a small amount of radioactivity that is given, as you can see, 150 megabecquerel, enough just to visualize the cancer. Once we have this scan and we see that there is enough PSMA expression, the patient might qualify to be treated as well with lutetium PSMA. So this time, not using a diagnostic radionuclide, but this time using a therapeutic radionuclide, which is lutetium-177. And you can see in the subpanel B, the patient has already got an injection. Usually, nowadays, the dose preferred is 7 gigabecquerel, so it's much higher. It's another magnitude of order when compared with the diagnostic dose. And you can see here the image performed 20 hours after the injection of this lutetium PSMA. So this is actually possible just because the patient has enough radioactivity. We have gamma rays, and we can therefore image the patient. And this allows us during the treatments, because usually the patients are treated with 4 up to 6 cycles of lutetium PSMA, we can evaluate every time how the patient is responding. So every time we will perform whole body planar images and a SPECT CT, usually for dosimetric purposes, and we can evaluate this result. As you see, we are not dealing only with beta particles, with beta emitters. If you click once again, please, we will see that nowadays we are also using alpha radionuclides. Alpha radionuclides are actually even more, I would say, aggressive than the beta, because they can deliver a higher level of energy to the cancer cells, so therefore they are more efficient. And nowadays we are having in our armamentarium terbium, astatine, bismuth, radium, thorium, and of course the actinium-225, which is, after the lutetium-177, one of the most known tracers. And as you can see, we have this patient having, once again, extensive metastatic deposits in the appendicular, but also in the axial skeleton. And we can see the patient has a PSA, the tumor marker is almost 3,000 nanogram per milliliter. He was treated with 3 cycles of actinium PSMA at an interval of 2 months. And you can already see the incredible result in which almost all the metastatic deposit has resumed. And this patient was treated with 1 consolidation cure of actinium PSMA. And you can see not only that the image is actually perfectly clear right now, all the metastatic deposits have disappeared, but we also see that there is a biochemical response. The PSA is now unmeasurable. And this nowadays we are also able to combine the alpha with the beta particles. It's the so-called tandem therapy, in which actually in patients that are not responding anymore to beta particles, like you can see here in the subpanel A, this is a patient who was treated with lutetium, but you can see at some point in the subpanel B, he is becoming progressive. So this is a sign he's not responding anymore. And in this case, providing and offering the patient 2 cycles of actinium PSMA, we can already have a very good response. And after 1 extra consolidation cure, you can see that the patient is again having a clear scan with an unmeasurable PSA. So really an incredible result. What I have already explained is that we perform the PET-CT scan in order to see if there is expression on the scan. But the most important thing is, depending on the expression that we are seeing, to decide if the patient is a good candidate or not. Now, I have to admit that the nuclear medicine community is still dealing with what is actually the criterion in order to say this is a suitable patient. It's not only a visual, but also a semi-quantitative way in which we can appreciate this. And actually, we are basing our reports on the SUV max, so the intensity of the uptake, in this case of PSMA expression in the metastatic deposit. But we don't really know, and we don't have a cutoff level. Is it 10? Is an SUV max of 15 or 20? Anyhow, 20 is considered already a high SUV max, so almost all patients having an intensity higher than this will be considered suitable. But this is not enough. So in this case, I would like to ask you, even if it's impossible to answer or only by chat, if this patient is candidate, because the SUV max is 70. So theoretically, yes, it is a good candidate because it has a high expression. So we know that we will hit the target with our therapy. Unfortunately, seeing this PSMA, but also comparing with an FDG, which gives us information, is glucose, and it gives us information about the metabolic activity, we can see that Actually, everything that is in blue is PSMA positive. So yes, we can treat and the patient will respond. But everything that is here in dark red is actually corresponding with tumors that were not being PSMA expressing. So in this case, they are metabolically active, but not expressing PSMA. These are probably the most aggressive clones that the patient is having, which will not respond to our treatment. And this is just because, as you already know, that prostate cancer is one of the most heterogeneous diseases that we have. And even in one patient, we have these PSMA positive, but also PSMA negative clones, explaining why the patient will respond or not respond to our treatments. And I think from PSMA we can move. I will not going into details, but nowadays we also have some other targets like fibroblast activation protein inhibitors, which are just present because the neoplasms share a tumor microenvironment which is rich in cancer-associated fibroblast, and therefore the FAP is a transmembrane proteases which will express these CAFs. So the last results that we have from the literature show us that it might be a possibility to use in kidney and in bladder cancer, and this will be explained later on by my colleagues. And we are also looking for alternative tracers, especially for the bladder cancer, where we know that we don't have too much possibilities, too many tracers to use. Anyhow, the successful PET tracers, what we would like to have in clinical practice is to have PET tracers with a suitable structure, with a stable labeling, well-defined molecular target, high specificity for cancer biomarkers. Think about this FAP that I just explained you, the Nectin-4 or the CA9. But we also want them to have a rapid urothelial tumor uptake and a clearance from the blood, so disappearing from the blood and not having a long retaining time, an optimal half-life, and more especially and important, to have a reduced urinary excretion. This is one last example about the carbonic anhydrase 9, which is a very nice hypoxia tracer suitable for both bladder cancer as urothelial tissue, which we will not find on the scan, so only the bladder cancer, but also especially the clear cell renal cell carcinoma will show a high expression, more than 70%. And this tracer is potentially to be used for both diagnostic and therapeutic purposes. And Nectin-4 is also the last one that I want to present, which might be important for the urothelial cancer. My future perspectives are that now we are looking for some other tracers like terbium. We are looking for alpha emitters, astatine, and also some other pan-tumor targeting agents. And I'm sure that in the future, these innovations in theranostics are really able to broaden the scope of precision medicine. And with this, I would like to thank you for your attention.
Thank you very much. Daniela was absolutely, clear and very basic information that are probably those that we need as urologists to understand exactly how theranostic works, because this is the key for our practice. So just going in order, so the key factor is obviously to identify the right biomarkers that may be targeted by a ligand, and then by adding a ligand to a radiation particle that may struck to the cells, even macroscopically, even those that you cannot see on the camera, the gamma camera, I guess.
Yeah.
Yeah. So this is introduced to me a couple of questions about, first and foremost, how do you know the radiation dose that actually is delivered at the cellular level? And the second question, well, okay, I'll let you to address this one, and I will make the second one.
So in clinical practice, after each cycle, we will perform a scan in order to see, on one hand, if we hit the target, and on the other hand, by serial cycles of lutetium, PSMA, or actinium, or whatever treatment we are giving, to evaluate if the patient is responding. So visually, we already have an idea of what is happening. But in practice, we are also performing a SPECT CT, so we are able to perform dosimetric measurements in order to see what is the level and what is the absorbed dose in different organs, but also in the tumors, so that we can evaluate our treatments. So
great, thank you. So the next question is whether, completely different is the circumstance of a patient with 5 spots respect to those cases that you showed us. But I guess that the pharmaceutical product is the same. So is there any chance, I don't know, especially in a period where there will be shortage, a continuous shortage of these rare elements, to adjust your dosage or in terms of what is the overall volume of tumor?
Absolutely. At this moment, we are giving everybody the same dose, which is quite, we feel like we are not doing the right thing, because indeed, probably when you have 5 spots, you should give another dose. On the other hand, we should base our treatment really on the type of the metastatic deposits we have. I can imagine that if you have bone metastasis, you will need a higher absorbed dose than when you have lymph node metastasis, for instance. And this is something going on. We are actually collaborating with also colleagues from the radiation oncologists, so radiotherapists, in order to establish what is the optimal dose for different types of metastasis in order to kill the cells and not to leave any rest there. So it is a little bit premature right now to discuss and to tell you how shall we do, but it's work in progress.
It's very interesting. So last question is about, we know that, for example, for the PSMA, you will have parathyroids, the salivary glands that will be affected. So if the radiation dose delivered by the radioligand may hit the cancer and kill the cells, the tumor cells, so obviously this may cause also side effects to the patient.
Absolutely.
But are these reversible, or there might be higher chance that these might be not reversible?
Thank you very much. It's absolutely a great question. Yes, it depends on the setting and it depends on the radioligand. When we are using lutetium-177, usually it is a reversible process. When you are using actinium-225, so an alpha, a strong alpha emitter, usually is a permanent destruction of the salivary glands. But it's also depending on which setting. I have treated patients in the hormone-sensitive and even hormone-naive patients for research purposes. Those patients had absolutely no xerostomia, no dry mouth that we were able to see in the castration resistance. So probably the fact that this castration resistant have already chemotherapy and some other agents that are also affecting their salivary glands and the mucosa will influence how these patients will respond. But usually with beta, it is a reversible process.
Very interesting. So I'm now pleased to introduce again Dr. Unterreiner, and she will give us some hints about what is in the pipeline and actually the current evidence of the pipeline for future indication of theranostics in prostate cancer. We also some clinical cases. Thank you very much, Dr. Unterreiner.
Thank you very much for the introduction. So in the next minute, I will talk about theranostics in prostate cancer, from the castration resistance to the hormone-sensitive setting. So here are my disclosures. So in prostate cancer, you can target, as Daniela already mentioned, with different nuclear medicine methods, the bone microenvironment, the metabolic activity, as well as, and this is what we already discussed, the PSMA, and this is my focus within the next minute. So as we heard, it's a transmembrane protein, which is highly expressed on primary and metastatic prostate cancer, which makes it as a critical biomarker for diagnosis and targeted therapy. And as we have heard, you can address PSMA with different radioligands. And this leads us to the statement of nuclear medicine. We see what we treat, and we treat what we see using different molecular diagnostic and therapeutic methods. PSMA radioligand therapy shows in the mCRPC setting an extraordinary great response rate to therapy, leading to significant reductions of the PSMA positive tumor mass. For example, you can see this case here. This patient had more or less no tumor mass after 4 cycles of PSMA RLT. And especially caused by the results of the VISION trial and the approval of PSMA radioligand therapy for the progressive mCRPC by FDA and EMA, the PSMA RLT has become more and more prominent within the last few years. So how was the design of the VISION trial? The inclusion criteria were progressive PSMA positive mCRPC, a pretreatment with at least one previous ARPI, and a prior taxane-based chemotherapy. And patients were stratified into the PSMA radioligand arm or the standard of care arm, and the endpoints were rPFS and OS. And the VISION trial could then show that PSMA radioligand therapy has a significantly improved PSA response, a prolonged rPFS, and a prolonged overall survival compared to the standard of care. And also the time to worsening of the quality of life was significantly delayed with PSMA radioligand therapy. So the therapy trial compared PSMA radioligand therapy with cabazitaxel, also in the mCRPC setting, and could show that PSMA RLT leads to a higher PSA response, less grade 3 and 4 adverse events compared to cabazitaxel. And to sum up these both trials, so VISION and therapy, we can say that PSMA RLT is currently located in the mCRPC setting after at least one taxane-based chemotherapy. And this is also what the current approval of PSMA RLT by the EMA says. So currently we use PSMA for progressive PSMA positive mCRPC that had a prior treatment with AR pathway inhibitors, and the patients underwent normally taxane-based chemotherapy before. And to give you here a patient example in the mCRPC setting, so the patient I would talk about had an initial diagnosis of a de novo, high volume, high risk metastatic prostate cancer. He underwent prior therapies with ADT, with docetaxel, abiraterone, and enzalutamide. And after these treatments, he showed a progressive disease and underwent in this progressive mCRPC setting a PSMA RLT after the PSMA PET, which you can see here, demonstrated a PSMA positive disease. And after 6 cycles of PSMA RLT, the patients had a significantly reduced tumor mass as well as a significantly reduced PSA value, as you can see it here in red. And in March 2025, the FDA expanded the indication for PSMA RLT to include also patients with mCRPC who have been treated with ARPI, but are considered appropriate to delay taxane-based chemotherapy. And background of this extended indication and FDA approval was the PSMA-4 trial that tested PSMA RLT in taxane naive patients. So let's take also here a quick look at the PSMA-4 study design. So the here included patients were taxane naive candidates that were eligible for change in ARPI after they progressed once on a prior ARPI therapy. And the patients were stratified also here into a PSMA RLT arm and a change in ARPI treatment, and a crossover between these arms was allowed upon rPFS in the RP change group. So that means that the PSMA-4 trial is now located a little bit earlier in the treatment sequencing compared to VISION. And PSMA-4 trial could show that PSMA RLT prolonged rPFS relative to ARPI change with a good safety profile. And regarding quality of life, it was stated that PSMA-RLT might delay worsening of patient-reported outcomes versus ARPI change, while overall survival did not show a statistically significant difference between the both arms. And it may be, of course, that these results were confounded by the allowed crossover from ARPI change to PSMA-RLT arm. And I want to give you also here a patient example in the prior chemotherapy setting. So this patient was treated in our clinic in a compassionate use program and underwent prostatectomy, had a prior therapy with ADT, abiraterone, and an LHRH agonist. And after these therapies, he showed a progressive disease and underwent PSMA and RLT. And also here, as you can see it on this slide, 6 cycles led also in this patient to a significantly reduced tumor mass, as well as to a really excellent PSA response. The last study I want to mention is the PSMA addition trial that included untreated or minimally pre-treated MHSPC patients. The first arm was PSMA-RLT plus ARPI plus ADT. The second arm was ADT plus ARPI. And also here, crossover was allowed to the PSMA-RLT arm when the patient showed a progressive disease in the second arm. And so this means again that we are now again earlier in the treatment sequencing of prostate cancer compared to PSMA-4 and VISION. Primary endpoint in PSMA addition is rPFS. Key secondary endpoint is the OS. So what does minimally pre-treated mean? So this means that the patients were allowed to have a short exposure of 45 days to LHRH and an allowed short exposure to ARPI also for 45 days. The PSMA addition is still ongoing, but I would like to show you some interim results that were presented last year at ESMO in Berlin. So after a median study follow-up time of almost 24 months, the risk of rPFS or death was significantly reduced by 28% in the PSMA-RLT arm compared to the control group. And in addition, OS analysis today demonstrates a trend towards an OS benefit in the intervention arm. And there were no really clinically significant differences regarding time to worsening in health-related quality of life and pain. To show you also here a patient example from our compassionate use program. So this patient here underwent a prostatectomy and a lymphadenectomy, but underwent no anti-hormonal treatment at all due to a severe dilated cardiomyopathy. So now, together with our urologist, we decided then that he can underwent a PSMA-RLT in this MHSPC setting as part of an individualized treatment plan under compassionate use. And as you can see it here, also 4 cycles of PSMA-RLT have already led to a good response in this patient. So as you can see in this overview, there are currently multiple ongoing trials in even more earlier stages of prostate cancer than PSMA addition. And some studies also combine PSMA-RLT with treatments such as SBRT. For example, the LUNA trial is doing that at UCLA. To sum it up, PSMA-RLT is a tablet therapy for progressive mCRPC in an after taxane chemotherapy and after ARPI setting. In the US, PSMA-RLT is already approved for mCRPC patients after ARPI treatment to delay chemotherapy in mCRPC. And additionally, it could be shown that PSMA-RLT prolongs the time to worsening of quality of life in mCRPC patients. And currently, there are multiple ongoing trials evaluating PSMA-RLT in even earlier disease stages. So thank you very much for your attention.
Thank you, Elena, very much, and very much, again, for the very clear presentation, also for the amazing experience that you have collected, especially for the compassion program. That is something unique, I guess, in Europe. For testing, lutetium. This is the reason why your country is probably the most advanced in Europe, or among the most advanced in terms of having in a clinical practice experience of in general speaking theranostics. So obviously, so I had some questions because. We have seen that there are some trials done and others ongoing in completely different scenarios. What is your feeling about which is the best one fitting for these for the lutetium?
Yeah, I think this is a very important question, and I think a big matter of debate. What I've seen, or what I've just demonstrated on the last slide, we have, and what you've mentioned, we have so many trials ongoing, even in the setting prior prostatectomy to reduce the tumor mass. And of course, everybody is asking the question, where is the best position for PSMA-RLT? And I think what's important here, and Daniela already mentioned that, I think we have to wait also for some of the results of these trials regarding, I don't know, further outcome of the patients. I think dosimetry will play a big role there because, of course, when we put lutetium very early in the treatment sequencing, maybe we have some issues regarding xerostomia, what we don't know at the moment because the patients are younger. Maybe it's also good that they're younger, but I think it would, of course, for NUCMED, it would be great if PSMA-RLT moves as early as possible in the treatment sequencing, but I think we have to do it baby step by baby step to see where the best position is, definitely. But of course, I think in the MHSPC setting, it's what we have, the first results on addition are quite great. This is something we can definitely sum up together.
Another question is related to how trials nowadays have been designed. So, for example, I saw so for the PSMA-4, I was a little bit thinking, whether the design of the study was appropriate by, as a comparator. We had an RP that we know as a challenge RP is very unlikely to, in the sequence RP may function in 15% of the cases. So that's why I'm not sure how much is, the value of overall the study, as well as also as another one in which I participate in the oligometastatic recurrent, the oligorecurrent, which is the PSMA delay, castration delay, where actually the study design is SBRT, so the targeted radiotherapy to the spotted lesion, plus minus lutetium. So also there's very awkward sometimes, the comparators, and I don't know what you think about, are we designing well these studies, these trials, or is it a difficult question now to address?
It's a difficult question, right? Because I think a lot of smart persons were thinking about these designs. And of course, I think you always find pros and cons regarding the design of this trials. And of course, I totally agree with you. I think it was a big matter of debate how PSMA-4 trial was designed, because a lot of urologists told us, I never do this second arm you are put patients in. So this is, I think, it's still a big issue, definitely. What I also really like, and this is what you mentioned, is this combination of PSMA-RLT to other treatments such as SBRT. This is also the reason why I mentioned very briefly the LUNA trial, what my former boss at UCLA did, because I think also especially in the oligometastatic setting, we have seen great results in addition to SBRT to really reduce the tumor mass. And I think this is really something that could really help us all. Yeah.
Really interesting, really very interesting. So, okay, thank you very much, really, Elena, for your
Thank you.
for providing us all this very important information and also sharing with us your experience in the clinical practice. And now it's a turn to another superstar, Dr. Casuscelli from as I mentioned before, she's a urologist from Munich, and she will tell us, what is in the pipeline, because at the moment there are no phase 3 trials on theranostics in the other cancers, but there's lots of work there that is going on. Thank you, Josefina.
Well, thank you so much for the presentation and for the invitation. So as a urologist, I am basically just a customer or end user of what the nuclear medicine specialists produce for our patients. However, when I have to talk about bladder and renal cancer, what do we know? What do we have so far as experience in theranostics? It's not as successful yet as in prostate cancer, but of course we have here cancers that are more rare and potentially difficult to treat. And in particular, bladder cancer is really challenging. We have a high rate of recurrence and variable aggressiveness. And in the metastatic setting, it's really difficult to treat. For the imaging, we have FDG PET as a good widely used in oncology, but in bladder cancer, it's a little bit limited due to the urinary tracer excretion and also variable tumor uptake. So we need to do better for imaging. And it's a good assessment tool for nodal and distant metastases, but it's purely diagnostic, so potentially theranostic as an agent, and it just plays a role in disease monitoring and identifying patients. So as Professor Obrey already mentioned, FAP is really promising in in bladder cancer, because we need really molecular imaging, and this fibroblast activating protein is membrane bound, and it's overexpressed on fibroblasts that are cancer associated and are in the tumor microenvironment. So they are the key drivers of tumor growth, invasion, and therapy resistance. And unlike FDG, which reflects the metabolism, FAP imaging visualizes the stromal compartment that supports that framework that fuels the tumor progression. And it's expressed in over 80% of advanced urothelial carcinomas, making it also an attractive theranostic target. And we have some radio-labeled tracers like gallium-68 DOTA FAPI, gallium-68 FAP2286, and that bind selectively and have a high sensitivity and theranostic potential. And the emerging data that we have so far suggests that FAPI PET imaging can outperform both CT and FDG PET in urothelial carcinoma. And there are early studies that show intense uptake in the primary tumor, but also in the metastases, and can also detect lesions that were missed on the CT, indicating that conventional imaging may underestimate the disease extent. And as illustrated here on the left, several lung and abdominal metastases are poorly visible on CT, but clearly highlighted on FAPI PET. Similarly, when comparing FDG to FAPI PET on the right, FAPI consistently provides higher contrast and better lesion visibility. And importantly, Lena Unterreiner and our team at LMU demonstrated that FAPI PET before radical cystectomy achieved significantly higher sensitivity for detecting Local regional lymph node metastases compares to CT, which is a key unmet need in bladder cancer staging and then planning. Overall, very promising next generation imaging for bladder cancer, but can we also use it as a theranostics or therapeutic agent? So there is a trial, the Lumiere trial. It was phase 1 to 2 that evaluated the safety, the dosimetry of and the efficacy of 177 lutetium FAP 2286 in patients with advanced positive, so FAP positive tumors, and they had 27 patients across 6 sites in the United States that got like 6 cycles. And this is a ligand. So FAP 2286 is a cyclic peptide that binds to FAP, and it is labeled with lutetium, making it a true theranostic agent that enables both imaging and targeted radioligand therapy. So the treatment was well tolerated from the first data that we have that have been reported. There were a few dose-limiting toxicity and low-grade 3 or higher adverse events. And there is now a phase 2 ongoing, exploring FAP 2286 as a monotherapy in combination with chemotherapy. But unfortunately, in this trial, urothelial carcinoma tumors are not included. So there are just other tumors that are solid tumors involved. And I wish I could present more cases of theranostic application in bladder cancer, but in fact, we have very few experiences. This is actually one patient in Munich so far that had a very or highly aggressive metastatic urothelial carcinoma and was treated at the Technical University by Lena Unterreiner with 177 lutetium and then FAP 2286. And the patient had extensive metastatic disease of the lungs, of the liver, lymphatic tissue, and had also bone metastases from bladder carcinoma. Had also a complex histology, to be honest, with partially plasmacytoid and neuroendocrine components, and had failed several treatment lines of the approved regimens. And given the very high FAPI uptake that was detected with SUV max above 11 and multiple lesions in the liver, he was selected for FAP targeted therapy and received 3 cycles in total, showing initially a very good response. However, in this case, it was also highlighted that there is an important limitation of this treatment. So bone marrow exposure can be dose limiting in heavily pretreated patients, also with osseous metastases. And therefore, radiochemical optimization strategies are being developed to reduce the bone marrow dose and improve the tolerability in this patient. So overall, this case illustrates both the strong theranostic potential of FAPI-based therapy that should be definitely refined. And as you already heard, we have other potential targets in bladder cancer. Everyone is aware of Nectin-4 as now basically the very important target that has shifted the paradigms for the systemic treatment with enfortumab vedotin. And now it is also a very strong area of research to understand the mechanism of acquired resistance to enfortumab vedotin, which is not really just driven by Nectin-4 loss, also Nectin-4 expression loss. And this is there are different strategies to overcome this, like with radioligand therapies, who could be potentially an option for these patients. And in fact, there have been There has been a Nectin-4 imaging approach using a PET tracer, gallium and 188, which is a bicyclic peptide with a very high affinity for Nectin-4. And this is, for the first time, non-invasive assessment of Nectin-4 expression. And you can see here that Nectin-4 positive lesions have a high contrast and a tracer uptake. This is probably something that is notably better than FDG PET for those patients. And so what was seen also in this publication, that is this tracer uptake correlated also with membranous Nectin-4 expression, suggesting that this could be a valuable tool for more precise patient selection and also treatment planning. And this kind of imaging is being tested in the University of Dresden, also in Germany. But the ability to image membranous Nectin-4 expression using tracers can also give a new target for the radiopharmaceutical approaches. And there are both antibody-based and mini-protein-based approaches that are advancing, including agents like AKY-1189 that can be used for both imaging and therapy. So this progress has been translated into early clinical testing. There is one study, the Nectin-2 phase 1b, that is now enrolling patients that are expressing Nectin-4 in tumors, and there are also cohorts with bladder cancer patients. So overall, imaging is rapidly evolving, also in bladder cancer, moving towards Theranostics applications, and we have promising results in basically laying the groundwork for FAP directed radiopharmaceutical therapies. At the same time, agents targeting Nectin-4 may enable more precise systemic therapy allocations and eventually also radioligands therapy. So here we have studies underway. But there is a growing interest, and probably we will hear about more potential targets in the next years. So what about renal cancer? It's also something where FDG PET is not really, the standard. It's not routinely used in RCC, also due to urinary excretion, variable tumor metabolism, and also about half to 60% of the RCCs are FDG avid. So it's not really, a good marker. However, high uptake is actually associated with a worse prognosis. So also we have here a need for a more precise functional and molecular imaging. And the biology enables basically a lot of targets in renal cell carcinoma. The loss of VHL tumor suppressor, which is a central biological driver, is something that has been analyzed, and you heard already about the first vasculature imaging via PSMA expression on tumor neovasculature, but also direct tumor cell imaging with the carbonate anhydrase 9, and together these pathways will move really the landscape in the RCC imaging. But also speaking of the radio sensitivity of renal cell carcinoma, this is something that has to be discussed, that it's outdated, the concept that renal cell carcinomas are radio resistant, and thus exploring both targeted imaging and radionuclide based systemic treatment is a very important approach. And one of the works that Lena Unterreiner was also involved in was exploring the sestamibi SPECT CT scan, which is a mitochondrial tracer, so has an uptake in the mitochondria, and which is very important to assess whether patients have small masses that are benign, like oncocytomas or clear cell renal cell carcinoma. And other options are to look at c-Met, cell surface tyrosine kinase that is frequently overexpressed in metastatic RCC. This is something that can be visualized. Also, one of the works of my colleague from the nuclear medicine department. With this imaging technique, we can visualize tumors and potentially also predict the therapy adaptation, because cabozantinib, for example, as one of the TKIs, is a MET inhibitor. And I am just going very briefly over CA9 because it has already been elucidated, a very important marker that is expressed in the tumor cells in renal cell carcinoma, but also, as I already mentioned, PSMA more in the neovasculature. And the PSMA PET is something that can be also used to visualize the renal cell carcinoma in metastatic patients, and eventually could also be used as a theranostic. On the theranostic side, there are early attempts actually also in our department, but so far they have been pretty disappointing also because of the rapid tracer washout when PSMA is also basically mainly expressed on the tumor neovasculature rather than the tumor cells itself. And this is why there are trials ongoing to better define its role, but we are very in a very early stage for PSMA. CA9, also very briefly, there are studies that have been published and presented already with this tracer. It may better distinguish viable proliferative tumors from necrosis or scar tissue. And looking ahead, the ongoing trials, I think, are also very promising for this as a theranostic agent. There are different studies that are being performed in Europe, but also in the US and in Asia, showing that this small molecule peptide will probably change the landscape also for theranostic and renal cell carcinoma. So I think we need to go to the take-home messages, basically saying, yeah, we're still in a very early phase, but we have promising tracers also for renal cell carcinoma in the localized setting, but also in the metastatic setting to guide eventually the treatment, the surgery, but also the systemic approaches. And we have first trials ongoing with theranostics and radioligand therapy for this cancer too in uro-oncology. So thank you very much for your attention. I didn't see questions, but
yeah, there will be questions anyway.
Yeah.
So I think, I don't know whether Daniela and Lena could also open the microphone as well. So first I have a question to you, Josefina, is about, I've seen, I'm very interested, especially in, the new application, bladder, especially in bladder cancer, without these exciting new biomarkers that might actually make the eventual PET CT also select patients to make a little bit more targeted the therapy, so to adjust the therapy to the patient who may benefit from the Vedotyne and those that not. So my question is about what you think about, you may actually have heterogeneity also in bladder cancer. So what do you think about also a potential treatment where you combine the FAPI target, which is a stroma, to the combined to the actual tumor target, like the Nectin-4. So I mean, is completely out of mind this option, but because you have two different targets, whether I don't know as happened in prostate cancer with the actin, with the alpha and beta particles, where the combination of two different targets in bladder cancer might actually have especially in the high volume patient, I don't know, have so how I mean it.
Yeah, so ideally, I wish we could use something like that, this kind of approach. We have to bear in mind that patients with urothelial carcinoma are older, more frail, have more comorbidities. So we have to be very cautious with these patients. And the patient that has been treated in the department by Lena showed it. He was, frail and the toxicity was really heavy, just having one target. So I think, it would be good to hit hard those tumors because it's a very aggressive disease and potentially also pretty heterogeneous. But I think toxicity is still a big issue, and designing trials or first phase early phase trials should be very cautious with this population.
My next question is to all of you is, we've been talking about Theranostics by now several years now, and still we are in a very early phase. What's the issue in making stronger or more substantial advances of Theranostics in urological cancers?
If I may start, I think.
Yeah, I think when we take a look.
Please, Lena, go ahead.
No, Daniela, please start. I will.
I think in our case, in the Netherlands at least, reimbursement is one issue because if you are able to provide these therapies, but you are not allowed to give them, it's A, painful, B, quite frustrating, to be very honest, and C, it prevent us to continue new developments, because when you perform this in clinical practice, there are a lot of questions, a lot of things that you are able to answer, that you are confronted with and forced to continue your work. Well, now we are a little bit stuck. In the Netherlands, we are almost for 1 year waiting for the administration in castration-resistant prostate cancer, which is quite a problematic thing. And the second one is the dosimetric part. I think from us as nuclear medicine physicians, it's also a discussable thing. Some of us, we would love to have dosimetry. On the other hand, we are aware this is something that has to happen on a very rigorous way in specific academic centers, and this is something that we still have to deal with. It's not happening everywhere, and it's time consuming if you want to do it proper. So these are two main reasons for why I think we are a little bit behind the schedule. Lena, please.
Yes, I only wanted to mention FAP therapeutics as example why it maybe takes longer than we wanted to take, because I think you all know, so we are trying to find the right FAP therapeutic agent, and this takes time, and we need a lot of, for example, compassionate use programs, maybe to identify which is maybe the best ligand, which does not have very high bone marrow toxicity. And I think this is also the reason why it takes a long time until we find the most appropriate therapeutic agent, or where we think that this might be the most appropriate one, and then we can start with a, phase 1, phase 2 trial. So I think it's a very long process to really identify the best possible option for the patient and for study design. I think this also may be a reason, right? This is what I experience at the moment regarding FAP, for example.
Any comment from you, Josefina, on this regard?
Well, Yeah, I see the problem basically. However, I mean, we will have more and more patients surviving the first line treatment. So it will be, so it is a need actually. So the patients will live longer. They will need more aggressive treatments also in the further lines. So yeah, I hope we can overcome these issues.
This is the last question, and then we need for question of time close. So how in the picture is impacting the difficulties in getting the actual the radio tracers? I mean, how frequent might be the shortage of the different components, especially in the very competitive world we are living today.
Can only discuss about the alpha. I know that there is at this moment already a shortage on actinium-225, the availability of actinium-225. And anyhow, even if this will turn out to be one of the best tracers that we can offer to our patients, we will not have it in Europe and in the world for all patients that will require. So therefore, I just showed you in the future perspective, I think finding new alpha therapeutics like terbium, astatine, bismuth, and something else will help us to homogeneous a little bit the landscape, because other way we won't have this for all the patients.
Okay, I think it's time to close. I think for me it was very interesting to listen all of you, all your comments and answers to the question, and I learned very much a lot from this webinar, and I guess most of the, if not all, the attendees. So definitely, I thank you very much for your work done this evening. And once again, I remember that this webinar for those that were registered could be reseen and rewatched. And there's one CME to be gained if you answer to the questionnaire. And I will invite all of you that are online to come and gather on Saturday, the 14th, I guess, in London of March, because this session, the imaging section session, will be in part also in run in combination, in collaboration with the ANM, the Association of Nuclear Medicine, the European one. And one of the topic will be exactly the Theranostics. So we'll go further deep in this exciting topic. Thank you very much, Daniela, Lena, and Josefina, to all the EU people, especially the School of Urology, and enjoy the evening. Thank you.
So much. Bye.
Bye. Thank you.